Good evening. Today's topic of discussion is gonioscopy. I am Aastha, a second year PG, and today's moderator will be Dr. Sripriya ma'am. So, gonioscopy is derived from two Greek words, gonia meaning angle and scopine meaning to observe. It was coined by Trantas, the term. It is just a way of assessing the angle of the anterior chamber. There are two techniques to do so, contact and non-contact. Gonioscopy comes under a contact technique. So Alexio Trantas was the first person to view the angle of the anterior chamber. He did so in a patient of keratoglobus. By indenting the limbus of the eye, he was able to view the angle structures, and he used a magnification of a DO in order to magnify it. Subsequently, Salzman used a convex contact lens in order to view the angle. Later, this was modified by Koppi to see the angle using a slit lamp. The modern day gonioscopy that we perform routinely in our outpatient was introduced by Hans Goldmann. So as you can see in this image, no matter how hard you try, we are unable to see the angle of the anterior chamber through torchlight or slit lamp examination. This is because the rays of the light that are leaving the angle, they do not exit the eye but are in fact reflected back into the anterior chamber. This is total internal reflection. So as we know, when a ray of light is going from an optically denser to an optically rarer medium, it gets refracted further away from the normal. At one angle of incidence, the refracted ray goes perpendicular to the normal, and this angle is called the critical angle. Any angle of incidence greater than that will cause the light to undergo reflection back into the media. The critical angle for cornea-air interface is 46 degrees. However, there are some exceptions, as in the case of keratoconus and keratoglobus, where due to a change in the curvature of the cornea, the ray of the light that is exiting the angle can actually enter the observer's eye. This is what was used by Trantas. So there are two methods of gonioscopy, direct and indirect. A direct lens provides a different interface for the light to pass through. Therefore, the light exiting the angle can now enter the eye of the observer, and you see an erect image of the same. Whereas indirect lenses, on the other hand, they use either prisms or mirrors, and that is how they reflect the light into the eye of the observer, giving us an inverted image. So let us take a look at some of the different types of gonio lenses. So direct gonioscopy, as we've already seen, it uses a steep convex contact lens, which is placed in contact with the eye. So this is the Koppe's lens, and it is a 50 diopter lens, which provides a 1.5 times magnification, and it can be a lot more depending on which ocular you are using. The patient needs to be supine, and a coupling fluid, which could be saline or viscoelastic, is used to bridge the gap. Some other lenses which are used, they are surgical gonio lenses, are the Swan-Jacobs lens, the Hoskin-Barkins lens, and the Leiden gonio lenses. These are the newer gonio lenses that we will find more often in our operating theaters. The Catena gonio prism comes in different forms. You have the right-handed version, the left-handed version, and even a hands-free version. It gives a magnification of 1.2 times. There is a Mori's gonio lens and even a Glaucos eye prism, which is a single-use angled lens, and it gives you a broad field of view. So these are impractical for routine use. Mainly, they are going to be used to see the angle of children during examination under anesthesia and for surgical goniotomy and MIGS. So these are some images of how the angle is going to look like through a direct gonio lens. The first two images are showing us KDB goniotomy being done, this through the Koppe's lens and this through a Swan-Jacob lens, while this is showing us examination under anesthesia through the Koppe's lens. Indirect gonioscopy uses...
The main difference is, because you're using a direct gonioscope, you will have to be tangential to the iris. Then only you will be able to see the angle. That's why the patient's head is tilted during the surgical procedure, or we bend down when we do an exam. That's why it's impractical in OPD, and so indirect gonioscopes came in.
So indirect gonioscopes, they use mirrors or prisms, and these are convenient to use in our outpatient setting. They are further classified as those requiring coupling agents and those who do not. So the lenses that require coupling agents include Goldman single mirror, 2 mirror, and 3 mirror, along with Thorpe. Here the mirrors are inclined at 62 degrees. The Goldman 3 mirror has 3 mirrors and a central lens. However, we will only be using the smallest semicircular mirror, which is angled at 59 degrees to perform gonioscopy.
And for the PGs, please remember the incline of the mirrors, because that is one thing that the examiners like to ask. Okay?
So the lenses which do not require coupling agents include the following. There is Zeiss 4 mirror, where all the mirrors are inclined at 64 degrees, Sussman and Posner. And there is also Allen Thorpe gonio prism, which is suspended by a frame, so it is self-retaining. Vogue 6 mirror gonio lens has 6 mirrors all inclined at 63 degrees. It is easier to visualize the entire 360 degree of the angle, as it compensates for some blind spots that are left with the 4 mirror lenses. You have lesser distance to move mirror to mirror, and a lot of clinicians have reported that it takes them lesser time in order to examine the angle. There is also a smaller area of contact, and therefore the patient is more comfortable. This is just showing how the image of an angle is going to appear in an indirect gonioscopy mirror. As you can see, when you look into the inferior mirror, you are going to be focusing on the superior angle. But it should be noted that this is just a mirror image. There is no lateral inversion. The PI, which is present nasally, is going to be seen nasally only in the mirror below. So the advantages of direct gonioscopy would be that you get a direct visualization of the angle, that the image is going to be as you see it. You can see a panoramic view, and you can also simultaneously compare both the eyes. Its disadvantages, however, is that the patient may lay supine and it is cumbersome and time consuming. Indirect, on the other hand, it allows us to do manipulation and indentation and can be used with the slit lamp. However, the image is going to be inverted. So, how do you perform an indentation gonioscopy? It is when you push the gonio lens on the cornea, and you push the cornea behind such that the aqueous present in the anterior chamber is displaced peripherally into the angles and the iris moves posteriorly. As you can see in the other image, that a closed angle will appear to be open. How is it different from manipulation? Manipulation is just when the patient, when you tilt the lens in the direction of the angle you want to observe. This is useful if you have a convex iris configuration and you want to have an over-the-hill view. Indentation, on the other hand, as we've discussed, is deliberately applying pressure on a closed angle to force it open. And if on indentation a closed angle is opening, that means it is appositional closure.
See, one thing where she says, no, when you indent, the aqueous is pushed back and then it pushes the iris back, and that is how you are able to see the angle. So remember, when the eye has very high pressures, you may not be able to indent and push the aqueous posteriorly enough to move the iris away. So just because in high pressure eye, and second thing, in a high pressure eye, you may have corneal edema, which can end up with having an epithelial defect if you try indentation gonioscopy. So if you have very high pressures and if you think that you're not able to open up the angle, do not conclude that it is synechial closure. Once you are given medication, the pressure has come down. Even in chronic glaucomas, please repeat your gonioscopy, because what you think as full synechial closure may still have a appositional component to it. Okay. Second is, what is the difference between the lenses with the coupling fluid and those that do not require coupling fluid? Can any of the PGs tell me what is the advantage, disadvantage of that? You must have read something. She talked about direct and indirect. What is the advantage or disadvantage? Why should we use a 4 mirror? Why not a Goldman 3 mirror? It's easier actually, Goldman single mirror. Can the fellows pitch in?
It require coupling agents is larger diameter corneal lenses. And
So-
indentation is not possible with those lenses.
Okay.
The indentation lenses are, compared to the coupling agent lenses, it is smaller in diameter, and we can perform indentation at the same time with those lenses.
Okay, if you do indentation with the ones with the coupling lens, what will happen? Anyway, it is resting on the globe. How does it matter if you indent it?
No, we are not pushing the central.
No, that is not the reason. When you press, what happens in the smaller ones, which is your non-coupling fluid ones, you press on the cornea, which is going to push the aqueous away. Whereas these lenses, where does it rest? It rests on the limbus and the sclera. So when you press, it is the sclera that gets compressed. So you can artificially end up closing the angle because the sclera is moving inside.
Okay.
So you'll get unnecessarily you'll think that the angles are more close than they are. And it is more painful, and being bigger, it is much more difficult to insert in deep set eyes, small palpebral fissure and all. And the need of a coupling fluid makes the other examinations also difficult. If you have to do fields or something for the patient, you'll have to wait till the stickiness of the coupling fluid goes.
Can anybody tell me the indications of gonioscopy?
You have to tell their names and tell them to tell one point. Do you think anybody will volunteer in Shankar Netralaya? I'm yet to see that generation. It's all gone.
Utkarsh, would you like to tell?
Ma'am, if a patient has a very high IOP, then before dilating the patient, we'll do gonioscopies to check
If it's normal IOP, you won't do gonioscopy.
Then also we can do.
To visualize the angle. Just say like that.
To visualize the angle.
Next.
If the VH grading on the slit lamp we see is less, so we go for gonioscopy to make sure about the angle.
Okay.
Diagnosed cases of glaucoma.
Yes,
Okay,
to differentiate
fine,
between
differentiate.
open angle and closed angle. Yes. If there's history of trauma or something, it will help.
So to see angle recession.
Yes.
Okay, angle recession or any other angle anomaly.
Okay, so we have diagnostic and therapeutic indications. Diagnostic indications is like you guys said. Another one would be to note the extent of neovascularization, and in post-trabeculectomy patients to assess the stoma. Therapeutic indications, on the other hand, would be in order to perform a laser trabeculoplasty, to do an iridoplasty. Sometimes an indentation gonioscopy can be used to break an attack of angle closure, and also to perform angle procedures such as surgical goniotomy and MIGS. So does anyone know the contraindications from that side maybe?
Any infection.
Okay, yes, surface infection. Okay.
Very good.
Oh, ma'am, in case there is a corneal
defects.
edema or endothelium.
Corneal epithelial defect. Okay, good. Next. Yes,
Yes.
penetrating trauma. Yes. Okay.
Open globe injuries. Then in hyphema. Why shouldn't you do in hyphema? One, visualization. Okay, you can't see much. Otherwise, yes, most important, you can cause a rebleed.
So now coming to the identification of angle structures, let us look at the image on the right side. So here you can see the Schwalbe's line over here, which is we consider the anterior most structure of the angle. Behind that, there is this portion which is the scleral canal that houses the trabecular meshwork and the Schlemm's canal. The posterior part of the scleral canal, you can see this ridge sort of thing, that is the scleral spur, and behind that is the ciliary body. So the same thing can be correlated on the OCT image as well. Now let us direct our attention onto this pink line. This is nothing but the limbus. The limbus is not just a cross section of an area, it is a transition zone. So the anterior end of it is going to be where the Bowman membrane terminates, while the posterior end over here is going to be where the Descemet's membrane terminates, which is nothing but your Schwalbe's line. So during our surgeries, after we perform a peritomy, we all have noticed that there is a blue zone and a white zone to the limbus, and this is the region with where you can correlate them. So the blue zone is this area between the Bowman's membrane, and the white zone is the area behind it, posterior to it. Is there any questions here? So now how do these structures appear on gonioscopy? So from anterior to posterior, again you have the Schwalbe's line, the trabecular meshwork, the scleral spur, ciliary body band, and the iris root. So let's go structure by structure. So the Schwalbe's line is a fine white ridge. It is generally non-pigmented, but in this picture it is slightly pigmented. So as I mentioned earlier, it marks the termination of the Descemet's membrane. It is also the anterior border of the trabecular meshwork. It is identified using a technique called the corneal wedge technique. So in the corneal wedge technique, you see the junction between the two beams of light. You have an outer beam of light which is bright and fuzzy, and you have an inner thin beam of light. The junction where these two meet is going to give you the location of the Schwalbe's line. So this, however, when you're doing this, this requires a very thin and narrow beam of light, and it requires the oculus to be a little offset. There is a new technique that has been described in order to view the Schwalbe's line. It's called the Ortiz maneuver. In this, you do not need to offset the slit lamp, and while in the corneal wedge technique, you can see that we're seeing kind of a Y-shaped thing. Here it is an inverted V. So there is a white, they have marked it as a white line and a blue line. The blue line is the shorter line, and where that terminates would show you where the Schwalbe's line is. Its advantages is that you don't need to offset the slit lamp and you can use brighter light. So it's better for documentation. So coming to the
Just go back a bit. This corneal wedge, no? So if the corneal wedge is done with an oblique illumination by tilting the light to about 60 degrees, that is what your Ortiz maneuver is. Because the incident light and the reflected light don't come back to our eyes. Okay, so if the corneal wedge, if you see, it has a Y-shaped thing. The posterior one is much sharper. So that is on the Descemet's membrane. So the Descemet's membrane ends in the Schwalbe's line. From there, it forms on the trabecular meshwork, and then that line will crawl over your iris. So if it is in a continuum, it means that the angle is open. Suppose imagine the iris is convex. So what happens is the light goes on to the trabecular meshwork, and then you don't see it, and a portion of it is seen on the iris. So there will be a break in the arm of the Y. If the iris is, so then you know it is partially occludable. Whereas if you cannot see the insertion, the two beams of the Y, no, the two arms of the Y joining itself, that means the iris is lifted up all the way to the Schwalbe's line. So that is how you differentiate whether it is an open angle or closed angle. This really is very useful in especially light iris eyes and zero pigmentation eyes. That's when you will have a confusion whether it is open or closed. The fuzzy outer one is the one on the Bowman's membrane side, and the sharper, well-defined one is on the Descemet's membrane side.
So coming to the trabecular meshwork, it is a sieve of connective tissue. It is further divided into anterior and posterior. Anterior trabecular meshwork lies just adjacent to the Schwalbe's line, and it is non-pigmented and non-functional. Posterior is the pigmented and functional one. So its function is that it drains the aqueous through it into the Schlemm's canal, and a younger individual will have a lesser pigmented trabecular meshwork as compared to an older one. So why is it important to differentiate between the anterior and posterior trabecular meshworks is when we are going to be performing argon laser trabeculoplasty and selective trabeculoplasty. Next, coming to the scleral spur, as we've seen earlier, it is a projection of the sclera. It is the site of attachment of the longitudinal ciliary muscles. As you can see, it is always going to be seen as a prominent grey-white band between the pigmented trabecular meshwork and another pigmented layer, that is the ciliary body. So when you're doing gonioscopy, this is the line that's going to orient you the most as to whether the angle is open or closed. Next, the ciliary body, it is a pigmented band. If the trabecular meshwork is not pigmented, then this will be the only pigmented band in the angle. It is going to be broadly exposed in angle recession and also going to be wider in myopes as compared to hyperopes. The iris Next, coming to the iris root, it is the anteriormost part of the iris, which is the thinnest part, and this also inserts into the ciliary body. So some commonly confusing things is iris processes versus PAS, which is peripheral anterior synechiae. So iris processes are lacy cords of the uvea that run from the iris and insert into the trabecular meshwork. Whereas PAS is a pathological adhesion of the iris to the trabecular meshwork. Iris processes are narrow, irregular, and multiple, while PAS is more of broader and tent shape. When iris processes are visible, it means the angle is open, so you can see the underlying angle structures. But with PAS, it obscures the structures that lies behind it. One important distinction is that the iris process will never cross the Schwalbe's line, whereas PAS can. So these two images are showing iris processes. You can see multiple lacy projections which do not cross the Schwalbe's line. So coming to the angle grading systems, you can use slit lamp or gonioscopy to do it. We all know the Van Herrick's grading. Gonioscopic grading, one of them is the Schaefer's grading. It is based on the angle formed between the iris and the trabecular meshwork. Normally, it is supposed to be 20 to 45 degrees. Here, it is graded between 0 to 4, where 0 is a closed angle and 4 is a wide open angle. She's grading, on the other hand, is based on how many angle structures can you identify. This is also 0 to 4, but contrary to Schaefer's, 0 is wide open, whereas 4 is closed. The Spates classification is used in research. It is very similar to the ASOCT grading, and here it uses 3 variables: the insertion of the iris root, the width of the angle recess, and the configuration of the peripheral iris. Now, what we use in our hospital and how we document it here is we try to note the most posterior structure that we can see. We grade the trabecular meshwork pigmentation. We see the iris contour. On indentation, we note if there is any pars present, and also note if there is any other angle abnormality present. So how APGS classifies the angle is, it says that if you can see the scleral spur, it is an open angle. If the scleral spur is visible in only less than 2 quadrants, then it is a closed angle. If on indentation you cannot see any pars, then it is a primary angle closure suspect. If you can see pars, then it is primary angle closure. So the modified ISGEO classification also says similar things, and it is used in population-based studies. The preferred practice pattern says that if you cannot see PTM in less than 2 quadrants when eye is in the primary position without indentation, you can label this angle as occludable. And these patients have a higher risk of developing angle closure glaucoma.
Please remember primary position without indentation. Okay, so because sometimes people come back to us saying that no, it's open angle. Then you say, is it open? Then they say, yes, with indentation I can see all the angle structures, and so can I dilate. So without indentation, you should be able to see at least 180 degrees of the filtering portion of the trabecular meshwork, which is your posterior trabecular meshwork. You can manipulate, you can tilt the lens to see the angle, but you shouldn't need compression to see the angle. If you have to use compression to see the angle structures, it is a closed angle.
So now coming to the procedure of it, there are some prerequisites that you should have a dark room. The patient should be comfortably seated with his or her chin and forehead rested. The examiner also should be comfortably seated with his or her elbow supported. The slit lamp settings is, it should be a very narrow and small slit, low beam, high magnification. You must explain the procedure to the patient, instill 1 drop of topical anesthesia, and how to place the lens is that you ask the patient to look slightly up, you retract the lower lid gently, and you place the lens on the eye, and then you ask the patient to look straight. So you should hold the scope with 2 fingers, and the remaining fingers must take support from the face. Some commonly encountered mistakes is that we should definitely avoid bright light. It should be done in a dark room. Care should be taken that light beam must not cross the pupil. If you are seeing corneal folds, that means there is too much pressure on the eye, and you might see a closed angle as open. Whereas if you're not holding it with enough pressure, an air bubble might enter in between. When you're going to look at extreme horizontal angles, it is difficult to retain binocularity. And you should always perform applanation tonometry before doing gonioscopy. So now, keeping the instrument clean, it's done differently for different lenses. In the OPD, we use 2% bacillocid, but we can also use just soap and water. In OT, some lenses are sterilized with ethylene oxide, and some lenses can be autoclaved. So now coming to the abnormalities of the angle. So here in the first image, you can see that the angle is closed. You cannot make out the scleral spur or the posterior trabecular meshwork. But on indentation, the angle opens up. You can see the scleral spur, and you see that there is no pars. So this is a case of primary angle closure suspect. Next, you can see again a closed angle, which on indentation is going to reveal a peripheral anterior synechius. So this is a case of primary angle closure. This is an iris hump. As you can see over there, there's some kind of protrusion, but it's not pars. So this can indicate a ciliary body cyst. Here again, you're seeing a closed angle, and on indentation, it shows some abnormality. Can anyone tell me what that is? Okay, it is a double hump sign. Yeah, so this is a plateau iris configuration. So this is another image showing angle recession. One more feature is that the PTM is going to be more pigmented. So here you can see that there is a hole in the ciliary body region. This is called a cyclodialysis cleft. So this is the disinsertion of the muscles from the scleral spur. Here, this is also occurs as secondary to blunt trauma, But here you will get hypotony because the aqueous outflow is more. Here you can see fine vessels which are branching and they are crossing the scleral spur. So this is a case of neovascularization of angle. So Axenfeld-Rieger syndrome. Axenfeld anomaly is posterior embryotoxon, which is an anteriorly shifted Schwalbe's line along with multiple iris processes that also are attached to the anteriorly shifted Schwalbe's line. Rieger anomaly, on the other hand, is an Axenfeld anomaly along with some iris abnormalities like a thinned out iris and polychoria.
You can see in the left image, you can see the, through those iris strands, you are able to see the scleral spur and trabecular meshwork. That is how an iris process will be, whereas if it's a PAS, you cannot see anything beyond it, which is one of the differences that she told.
So these are keratic precipitates in the angle. Here you can see some greyish white fluffy material in the angle, and this is pseudo-exfoliation. This is another image showing hyperpigmentation in the angle. Can anyone tell me where we see hyperpigmentation? So you see it in pigment dispersion syndrome, pseudo-exfoliation, trauma. It can also be seen following an acute angle closure attack and after YAC-PI.
Any other reason? GSOC every day you'll see. Post-cataract surgery.
That's it.
And any drugs? Even patients on PG analogs. Sometimes if they are on unilateral PG analogs, when you are doing gonioscopy, you'll wonder whether you're dealing with a secondary glaucoma because that can also cause dense TM pigmentation.
So next is the Sample-Lacy's line. So this is nothing but pigmentation which settles anterior to the Schwalbe's line. So Schwalbe's line is the termination of Descemet's membrane. It's where the corneal curvature stops and the scleral curvature starts. So that difference of curvature can cause the pigments in the aqueous current to settle there, and that is what a Sample-Lacy's line is. It is seen in pseudoexfoliation and pigment dispersion.
Classically, Sample-Lacy's line is PXF. Okay. Pigmentation of the Schwalbe's line and in front of it.
So there are some new ways that we can perform gonioscopy. This is gonio imaging. The first image is showing us a picture of the angles taken through the iCam. This is the Nidec NGS1 system, which uses the gonio pen as a probe, and this is how it's going to show an image. Another novel way of documentation is where they have mounted the normal gonioscope only onto the slit lamp, and in front of the oculars they've placed a smartphone, and this is how they have documented and taken good quality pictures of the angles. So can someone identify what this is and what history would you like to ask the patient? Next row.
Same. This is just a recap of whatever findings she showed you. And that is the same reason why you normally we do gonioscopy in the right eye and then we do in the left eye. Everything, right eye first, left eye second, except if you are suspecting angle recession, then you always do it in the uninjured eye before you do it in the injured eye. Then only you will be able to differentiate the width in the angle, ciliary body width difference between the two eyes.
Okay, so this is a densely pigmented PTM with a ciliary body band. This is angle recession. Next person.
What is this? Yes, iris processes, and in this image on the right side, can you see in front of it one ridge? It's sort of lifted up and shiny. That is your Schwalbe's line. Can you point? That where the grey and white, that kind of a junction, no? So that's where the prominent Schwalbe's line is. It all indicates a juvenile angle.
Yes. Anterior insertion.
Why do you say anterior insertion? How you know anterior insertion from, say, cerebral closure? Both you can't see the angle much. One, the age group. No, they may be younger. Second, if you see lots of iris processes. They are not smooth like the PAS. Third, you'll have a flat iris contour with the iris contour rising up the angle like that if it's anterior insertion. Whereas PAS, you'll see the angle convex, and then you'll have one localized area where the iris is lifted up and it will go beyond the Schwalbe's line.
Yes. Can anyone identify this? Yes. Keratic
Could be pigments also. We do not know. Even old hyphemas, sometimes if the hyphema has gone, he'll have a subtle history of trauma. You may not see angle recession, but sometimes you'll see dark pigment clumps, sometimes even black spots in the angle, which indicates an old blood. So those are subtle signs of trauma. So what are the other subtle signs of trauma that you look for in gonioscopy? One is angle recession is straightforward. Difference in the pigmentation between the two eyes. Okay, if the right eye is just 1 plus and the left eye is 3 plus, you know he must have had some trauma or inflammation in the eye which has caused greater pigmentation because that eye pressures may be slightly higher. Always correlate clinically.
So this part is the sample AC line.
But when it is like this, patchy, you don't call it sample assist line. Okay? But this is more for identification that she has showed. It could be angle correction. This is a compression gonioscopy. We do not know.
This on body in the angle. Any questions?